to differentiate between descriptive and analytical studies that are commonly used in the surgical literature. So to try to demystify some of these words that you might see when you're reading about a research study or learning something. So by the end of the time, I hope you'll be able to list 2 descriptive and 3 analytical study types. And then I hope that we'll be able to know and apply the finer criteria to research study design. So again, poll everywhere, that QR code that's shown there. You can either scan that or go to polleverywhere.com A007. When you're there, it should ask you for your name, so you can put in whatever name you want. Okay, so definitions. A research study is the systematic investigation to answer a question using data from a population to create generalizable knowledge. So systematic means that there's a hypothesis, a plan, there's some organization by methods so that the data is collected and analyzed to give you a conclusion. Generalizable knowledge means that it's intended to provide information to others. So why do we do research? This is our first question in Poll Everywhere. Let's see if we can make it happen. So why do we do research? We do research to improve care for patients and community, to share your experience with others who could benefit, to understand the burden of disease in your setting, to develop problem-solving skills, or all of the above. All right, maybe I went a little quick there, and the next one will work. So yeah, it looks like we were able to change. Feel free. Yeah, so the goal of this one is to try to hopefully get this poll to work. Why we do research. Is it to improve care for patients and community, to share our experience with others who could benefit, to understand the burden of disease in your setting, or to develop problem-solving skills? Good. All right. 2 more seconds. It looks like there's a chat. Probably people are struggling. Oh, good. All right. We have people answering in the chat. That's great. Feel free to answer on the poll everywhere or in the chat wherever you want, or just wherever you are to say. So I would answer this with all of the above. There's no wrong answer here to this question, but I would say it's all of the above. Great. All right. So then there's going to be a leaderboard. Hopefully people will be able to respond. I think it lags behind a little bit. So a little bit of advice for those who are getting started with the research is to understand your why. What is your motivation? And I hope that your motivation is to improve the care for the patients that we have the privilege to take care of, and to understand our burden of disease a little bit better. Because some of the research that you might find maybe doesn't apply to where you are at your hospital. So the hope is to build it yourself to better understand. Also, research is a team sport. You should never be doing it alone. If you find yourself alone, then try to find a team, or at least someone, a mentor or a mentee, to do research together. Recognize that we are all learning. No one person has all of the answers. And if you do research well, you'll likely find that you have more questions than answers. You'll solve one thing only to find that you want to solve another thing and another, because we want to continue to progress. All right. So where does research happen? So I put this map on here. It is from the National Science Foundation. Back in 2016, they reviewed all of the literature and they looked to see where publications were coming from. So you can see the size of places like China, Europe, the United States, they've all increased, whereas a lot of our countries in Africa have shrunk down to show that not much research was coming from our setting. And I put this map up here not as a discouragement about the past, but as an encouragement for the future. So we have so much potential to add value to the literature because there's so often no one has looked at places that like in our hospital and in our countries, and we have really valuable information to share. So another question. A sample of a population should be, let's see. A sample of a population should be random and representative, small and selective, comprehensive and chosen by the investigator, or exhaustive and exclusive. So I'll give you a minute. There's a little timer over there. So try to select soon. You get more points if you act quickly. Good. All right. And now it's locked, so we will see. Good. So most people said random and representative, which is how I would answer. A sample of a population needs to represent the population well. So the population is the whole group that you're trying to study. But so often it's really difficult to study an entire population. So we create a sample from that population. So think about like when we do a census of our country, you go around to every single door and try to ask questions. That requires so many resources. If you can instead ask the question to a smaller group at random, but that group represents the population, that's a really important strategy on how to do a study well. Good. All right. Oh, now we have a leaderboard. Good. So we can see that John has taken the lead, but we have a lot of people coming up behind. And if it doesn't work for you, it's not a big deal. I see that there are 40 messages in the chat. I can't really check those in real time, so have fun. All right, so the study process, as we design a study, we want to be able to develop a research question, select a study type, collect and analyze the data, then interpret the results to report the findings. And that entire process is done in an ethical manner. So that's really important. I believe that there will be a week that's entirely devoted to the ethics of research, but that cannot be stressed enough. If you are doing research, you need to make sure that you have ethical approval to do whatever you're doing. And it's not really up to you or me to determine what is ethical. It is a group of professionals, a committee that's well represented to tell what is ethical and how to minimize the risk to our patients and to our hospitals, to our communities, and to us as researchers. Good. All right. So study design strategies. One study is not enough. So if you're on rounds and someone mentions one study, maybe be a bit hesitant because one study isn't enough to really change management. It can inspire us. It can help us to answer a question. But if that study totally contradicts every other study you've ever seen, you need to question it and take the totality of evidence to really come up with the best study for answering your clinical questions. So there are many different strategies for answering a question. The choice of what study type to design depends on many different factors, like the costs of the studies. What resources do you have available? Is it a feasible study, and is it ethical? So each design has its inherent advantages and disadvantages that limit and create bias. So if you ever go to a research conference, sometimes there will be someone in the audience who asks a question or tries to tell you that your research study is flawed. Yes, no matter what study you design, there will be flaws. And that's okay, right? We're just trying to come up with the best study design to answer the question. All right, so study designs, we kind of think of them broadly. We can break them up into groups, whether they're descriptive or they're analytical. Within the descriptive, we have ecological, we have case reports or case series, we have cross-sectional, like a survey. We have on the analytical side, more experimental. So you may have heard of like a randomized controlled trial, or observational, a cohort study, or a case control study where you kind of make comparisons. We'll talk a little bit more about these, and I think in the upcoming weeks, you'll be able to kind of dig deeper and learn more and more about each of these study designs. Good. All right. So another question. You publish a paper that reports your experience with 300 cases of small bowel volvulus. This paper would best be described as, so try to answer on poll everywhere. Don't worry about the chat. Maybe leave that alone. You're getting wrong answers anyway. So try to answer in the poll everywhere if possible. All right, so possible answers: hypothesis testing, descriptive, randomize, interventional. All right, so you publish a paper that reports your experience with 300 cases of small bowel volvulus. This paper would best be described. Let's see, just a couple more seconds. Try to answer on your device if possible, so you can take the lead. Good. All right. Let's see. So we have a lot of different answers. That's excellent. But most of us have decided it's descriptive. That's also what I would say that it might be. It's a description of the 300 cases of small bowel volvulus. There's really not a comparison group. You're not randomizing anyone to anything else. There's no intervention. And when you do a descriptive study, you're not really testing a hypothesis. You're more of generating a future hypothesis. Good. All right. So let's see if our leaderboard, oh, it's close, but someone is quick. John's been overtaken as now in second place just by a little bit. All right. So next question, you perform a well-designed study involving a sample population of married medical students at University Medical Center in Zambia. The findings from your study can be generalized or applied to which population? All married medical students at University Medical Center in Zambia, all married medical students at any medical school in Zambia, all medical students at University Center in Zambia, or all medical students within Zambia. All right, so a couple more seconds. Good. All right, we're locked. Let's see what we have. Good. All right. So I would agree with the majority, all married medical students at University Medical Center in Zambia. So the point of this question is to say that if there is a study, you really need to look carefully at that sample before trying to apply it to your population. So if there's a study that's done in the United States or Europe or Nigeria, and you're working in Kenya, maybe think, does this apply to my population? And if there isn't a study that's done in your population, maybe it's time for you to build that study, or just be a bit careful to see, does that research study, does that really answer the question that I'm looking for in my population? Great. Okay, John took it back. Wow, this is intense. But Wycliffe is coming up there quickly, and we do not know who guest 220 is, so they'll never get any credit. All right. Next up, you conduct a survey about the use of helmets for riders and passengers of motorbikes in 6 counties in your country. This would best be described as a case series, a cross-sectional study, a prospective cohort study, or a case control study. Good, a couple of seconds. So if anybody wants to jump in, it's the link is at the bottom of the screen, polleverywhere.com A007. Good. All right, so let's check it out. What do we think? All right, good. More debate here. Excellent. So I would describe this as a cross-sectional study. It is a snapshot in time, a survey that you are asking questions on a group of riders and passengers of motorbikes. So you could potentially create this into a prospective cohort study if you wanted to enroll each of these passengers and riders and watch them over time to see whether or not they are involved in a collision. That would be a great prospective cohort study. You could do a case series of riders and passengers to see maybe some of them were in collisions and had traumatic injuries. That could be a case series looking back at the riders and passengers and their experience. Maybe you want to do a case control study. You want to say, I think passengers are more likely to be injured than the riders. So I'm going to say that my cases are the passengers and my controls are the riders. You could make a study out of this question. But the question as it is, a survey would best be described as a cross-sectional study. Good. All right. Nice. Our leaders continue to lead. We have others maybe jumping up. Excellent. Some guests involved. Feel free to participate. All right. So which of the following is true of meta-analyses? Meta-analyses eliminate selection bias. Meta-analyses correct flaws in study design by using results from multiple studies. Meta-analyses measure the effect of an exposure on an outcome using the results from multiple studies. Meta-analyses use unique statistical techniques to arrive at conclusions. All right, you got to be quick. The guys in the leaderboard have figured that out already. All right, so it's now locked. Let's see what we got. Great. So we have a lot to learn from meta-analyses. So no one thought that it eliminated selection bias. I agree that the meta-analysis is only as good as the studies that it looks at. And what you'll learn about meta-analyses is that it takes a number of studies of a similar question, and it builds on all of them to try to come up with a consensus. So they measure the effect of an exposure on an outcome using results of multiple studies. But it can't really correct for the flaws in the study design. You can assess the bias in each of these studies. And the statistical tests, the techniques that you use are not unique to a meta-analysis. Good. All right. Great. Still, Shafar coming up in 3rd place. Excellent. Moving on. All right, we are making good progress. Thanks for your participation. Next question. So sigmoid volvulus is quite common where I work. So you are wondering if sigmoid volvulus is related to childhood abdominal trauma. You compare the rates of abdominal trauma in a group of patients with sigmoid volvulus to a similar group of patients without sigmoid volvulus. This would be a case control study, retrospective cohort study, prospective cohort study, or a randomized controlled trial. Hey, I think I went too quickly, so I think I may have sabotaged. It may not work this time. Oh, yeah, it's still going. All right. But now it is locked. So let's see. It didn't show up on my device. So if it didn't show up on your device, sorry. Okay, good. So I think that's a case control study. So you are looking at a group with an outcome, and that outcome is sigmoid volvulus, and you are comparing that group, those cases, with a group of those without the outcome, or those who do not have sigmoid volvulus. And then you're looking at an exposure, kind of going backwards in time to see if there's a difference. And the exposure that I thought of in this is abdominal trauma. I doubt there's a link, but I really doubt anyone's ever studied this. It maybe isn't even that relevant or interesting to study, but it is a good question to come up with a study design. Good. All right. So that's a case control study. All right, we have our leaderboard. So next up, you design a study to compare patients who had core breast biopsies done under ultrasound guidance with those done by palpation alone. So then you follow the patient to determine hematoma rates between the groups. So this is an example of a case control study, a randomized controlled trial, a cohort study, or a case series. Good. All right. Lock in your answer. I know we move fast. It's part of the challenge, part of the fun. All right. People were everywhere on this, except most people said cohort study. I like it. Okay. So I would call this a cohort study because you have your participants have undergone an exposure and you are following them throughout time to see if they develop the outcome. Okay, so it's kind of about when you're looking at the exposure and when you're looking at the outcome. So the exposure in this is the procedure. They had a breast biopsy done, a core needle biopsy. They underwent that exposure, and now you're following them to see if they develop the outcome. That's a cohort study. If the question had said, we grouped, we flipped a coin and some participants had it done with ultrasound and others had it done by palpation alone, that could have become a randomized controlled trial, but that's not what the question said. Good. All right. Next up, okay, man, hanging on to the lead. This is getting intense. We'll see if our technology works and we can keep going. You know, the difficulty is you never know if maybe someone's internet dropped. So, or if my poll just broke. Okay, so I like to include this slide to demonstrate the pyramid of evidence. And I hope that every one of you has done the online course the 2 weeks for introduction to research through COSEXA. If you haven't done it, and hopefully you'll do it next year as part of your COSEXA training. If you're not a part of COSEXA, you can go to Surge Hub and look at the COSEXA foundations of surgical and find this course within it. But you'll if you've done that course, you'll recognize this pyramid. So the point of this pyramid is to demonstrate the level of evidence. And you'll notice that our level of evidence builds as we go, but it has to start somewhere. So it may start with expert opinion. So that's your professors, your consultants, and their opinions on what to do best, right? So there's some utility to that, but often it doesn't have the foundation of evidence to help you answer a question. So that background evidence, that background information, the narrative reviews, that expert opinions, that really kind of sets the foundation. It begins us to help ask questions. Then we get into some of these descriptive or observational studies. So a case report. So if there's something that's never been seen before, the first step in evidence is to describe it, to say, you know what, I've noticed this series of patients, and there's something here that's different. And that helps to inform the world. So we watched this happen in real time with COVID-19. So the first person to report this said, hey, there's something wrong here. There's something bigger happening. We saw it with the association between smoking tobacco and lung cancer. That hard to start somewhere where a doctor noticed that he was seeing a lot of patients with lung cancer and noticed that they were being exposed to tobacco smoke. So that helps us to learn. But then as we go up, we can do a retrospective case control study or a prospective cohort study. So you can enroll patients, follow them over time to look and see, all right, we're watching patients who smoke or participants who smoke and those who don't smoke. And we'll see over time if they develop lung cancer. So interventional studies are great for medications, or let's say a new chemotherapeutic agent, or even sometimes a surgery if it's done really well and rigorously. But there's sometimes, even those they're higher levels of evidence, they don't apply. For example, if you're interested to see whether tobacco use causes lung cancer, do you think that we could design a study that randomized participants to smoke or not smoke? Would that be ethical? Would that be feasible? And do you think that you would sign up for that study to say, yeah, I'm willing to be randomized to smoking or not smoking to see if we develop lung cancer? No, not really. That would not be a very good study design to answer your question. So you have to think about this level of evidence. If there are not very many studies that have been done on whatever question you're asking, you're unlikely to find a systematic review or evidence-based practice guidelines about whatever you're interested in. But if there's something that's been studied again and again, and there are already evidence-based practice guidelines, you may want to question the need to spend your time and energy and money to investigate that same thing for your population. Unless there's something very distinct and very different, you may not really, that might not be your highest yield if there's already a good answer. So part of designing a study or thinking about a research study is to think about, has this question already been answered? Or is there room to ask again or ask in a different way? Good. All right. So the point of that pyramid of evidence is that there is value in each of these. Sometimes my residents, they think, oh, I need to do a randomized study. But often our foundation of even describing a case series or looking at a case control study, those might be more appropriate for what we really want to answer the questions that we have. So when we develop a question, when we think about why or how do we want to do research, think about a question that you've had as you take care of patients. So, these could be, let's say you're thinking about reducing infections in gastrointestinal surgery. It's a common problem. I think every hospital has this problem. So you might ask yourself, do probiotics reduce infection in gastrointestinal surgery compared to placebo? You might ask yourself, in pediatric trauma patients, does anticoagulation reduce venous thromboembolic events compared to no anticoagulation? Or does early tracheostomy reduce ventilator days compared to late tracheostomy in patients with traumatic brain injury? But I encourage you to come up with your own questions. When you're doing rounds, when you see a patient, I encourage you to be curious to see if something better could be done for your patient. And then go and search the medical literature to see what's already available. What do we already know about this question? And how can we answer it better? So when I think about designing a study, we want to use the finer criteria. Is the study feasible? Is it interesting? Is it novel? Is it ethical? And is it relevant? So for feasibility, do we have enough resources, time, and money to conduct a study? Do we have the appropriate number of subjects? Do we have adequate technical expertise with manageable scope to the project? So you might think about, well, I want to see if is it better to do on-demand versus planned takebacks to reduce intra-abdominal abscesses? Well, how many patients would you have at your hospital to study that question? So if you wanted to do it only at your hospital, it might not be feasible because you may not have the appropriate number of patients for whatever question you might have. So you might need to reach out to colleagues at other hospitals and make this a larger study. But then do you have enough resources, time, and money to make that happen? So you have to think about the feasibility of your study. Is this question interesting? Does it intrigue the investigators, your peers, or especially the population that you're studying? So this is where you want to engage the community, your hospital, your peers to say, is this interesting? Because you do not want to invest all of your time and effort in designing and doing a research study only to find out that no one really cared that you did it. No one's going to publish it because they're just not interested. You need to make sure that this topic, this question, is of interest to people. Is it novel? So does your study provide new findings to confirm, dispute, or extend prior work? So if the hospital next door already did this study, don't repeat it. Don't do the exact same study to just confirm what they've done. Unless you're really trying to confirm or dispute prior work. Like you think, oh, maybe there's a difference, or no one believed them, let me help them out. But don't just redo someone else's study. It needs to be novel. Ethical, again, it needs to be approved by an institutional research ethics committee to safeguard the main principles of ethical research. Relevant, is it applicable to scientific knowledge, health policy, and future research projects? Is your study going to drive science forward? Is it relevant? Good, all right, we're gonna try to do a few of these. Which of the following is the least likely to meet the finer criteria? Hopefully you haven't been logged out. Which of the following is least likely to meet the F in finer criteria? Publishing a case series that describes your institution experience with amputations. Publishing a randomized controlled trial that evaluates patients on who, it looks like I'm lost. Let me refresh. Publishing a quality improvement project that evaluates the use of hand sanitizer in your institution before and after an infection prevention course, or publishing a case report about an unusual presentation of gastric varices at your hospital. So which was the least likely to be feasible? And I think we got locked out there. That went really quick. It's okay. Okay, yeah, so I would agree that publishing a randomized controlled trial that evaluates patients who undergo laparoscopic versus open colectomy at your hospital, that's pretty challenging because you need to have enough patients to answer that question. It's probably not difficult or unfeasible to publish a case report about an unusual presentation of gastric varices at your hospital. You know, it might not be interesting or relevant or novel if your hospital has published that multiple times, but it's probably pretty feasible. Okay, that one's tough. See if there are any changes in the leaderboard. Which of the following is the least likely to meet the finer criteria? Okay, the R, this is the relevant of the finer criteria. Okay, assessing domestic violence risk for women admitted to your hospital, assessing preoperative nutritional status of patients at your hospital, assessing the risk of frostbite in Niger, or assessing rates of wound infection after urgent gastrointestinal resections. So which is the least likely to be relevant? Good. All right, we're locked out. Great, we're all over the place. So I would agree that assessing the risk of frostbite in Niger. I'm guessing, knowing my colleagues in Niger, it's pretty uncommon to have frostbite. So assessing the risk of frostbite, it might not be too relevant to the population at hand. I would say that domestic violence risk for women admitted to your hospital, I think that's a global phenomenon. And if you've got that figured out in your community, that's great, but most likely that's going to be a relevant topic. Assessing the preoperative nutritional status at patients in your hospital, that's pretty important for surgical outcomes. And assessing rates of wound infection after urgent gastrointestinal resection. Again, that's a problem that many of us deal with. And unless you've got it down to a 0, it's still an issue. But if you do have it down to 0, my guess is you're not recording properly, and there's still room for improvement. All right, John took over the lead. He's probably pretty quick at this and has figured out the system. For all of us that our system's not working, it's okay. Let's just cheer on John and see if anyone can take over. All right, which of the following is least likely to meet the E of the finer criteria? So try to remember what the E was as you answer this question. A study in Kenya that excludes non-English speaking patients because the investigators only speak English. A study evaluating the safety of a second-line chemotherapy agent for breast cancer where the medication may increase rates of DVT. A study where patients are compensated for their travel and the medical costs related to the study. A study where patients will experience discomfort due to the administration of a new medication. All right, you had to be quick. It's locked. Let's see. Good. All right. So each of these could have an ethical challenge, right? Each of these might have an ethical problem within it. But I think the biggest ethical challenge is a study that's in Kenya where our 2 official languages are English and Swahili, and we have so many other languages where we exclude people because they don't speak English. I don't think that's good. I think that's unethical. And it's up to an ethical review board to help us to make those decisions. But really consider that. You got to make sure that you're including the population that you want to study. A study evaluating the safety of a second-line chemotherapy agent, that could certainly have ethical challenges. So you want to make sure that you minimize the risks as you weigh the benefits of whatever you're studying. A study where you compensate, that could be unethical. What if I say that you're going to get 1,000 US dollars? Then you get into really unethical things like coercing patients to participate in your study. So if I would have included that, that could be very unethical. A study where patients will experience discomfort, again, that could be unethical. But you need to make sure you minimize your risks. So each of these could have an ethical challenge. Good. So here are some of the ethics, and I think that we'll get to the leaderboard next. I think that might be the last one. We'll see. We want to make sure that the study is ethical, that there's scientific validity to it, that we're fairly selecting our subjects, that we have a favorable risk to benefit. There might be risk involved. We need to make sure that the benefit is weighed accordingly, that there's independent review, that someone who's not affiliated with the study is reviewing it to protect you, the investigator, to protect the patient, to protect the community. We need to make sure that there's informed consent, and there's the key components to informed consent to make sure that that participants are truly informed before signing up for a study. We need to have respect for the enrolled subject, and we need to avoid conflict of interest so that there's no financial gain for the investigators. Good. All right. Oh, man, coming from behind. Shafar, congratulations. Let's all applaud. And thank you for participating. For those that were able to make it work, congratulations. For those that just kind of used the chat or just learned along the way, thank you for participating and learning as we went along. So as I close out my time, I still have a few more minutes. And I would be remiss if I did not point out some helpful resources. So I think each of us as researchers are always learning. We're always learning from one another. We learn from our patients. We learn from our mentors. We learn from our colleagues. So here are some things I've learned along the way to help do research. So openevidence.com, if you do not know about this resource, it has made literature review so much easier and so much better. So I would encourage you to use it. Go to openevidence.com. Right now, it's free. It's created by a group of doctors from Harvard, MIT, Mayo Clinic. You can ask some questions, and it will help to search the literature to help answer your questions. So I would encourage you to use that resource, even in your clinical care of patients. And if you're trying to think about a research question, start there and see if other people have investigated. There might be limitations, and you might be able to find that no one else has really thought of this question. Elicit.com is a free, there's a paid and a free version. I always stick with free things. I think you can often do things without paying. And I would really encourage you to find the free stuff before you go out and spend money on any kind of research tool. So it helps to do literature review as well. And then as you search the literature, PubMed Central, it links to open access journals. Africa Journals Online is really important to find research that's been done in our context with our patients and is relevant. So go to Africa Journals Online when you're trying to search the literature. There are multiple courses just like this one that might give you a more in-depth background. So the National Institute of Health Principles and Practices of Research is an online course that you register for, and you take it over a course of months. The Global Health Training Center is a website. It has great options. Coursera and edX, they have courses that you can audit. And the World Health Organization has some research methodology courses. It links to others, especially those that are free. So you can do those courses for free. You can sign up for a certificate for a lot of money, but it's the same course. So just get the best of it. So some analyses, tools, EpiInfo, Google Colab, RStudio. These are free statistical software packages so that if you do get into statistics, but if you're struggling with statistics, recognize that research happens on a team. You might need to expand your team. And so many of the projects that we do, in order for them to be feasible, they don't require advanced statistical techniques. For writing, Google Docs is a great way to collaborate. Zotero, when you're trying to manage all the references, is a free reference management system. If you're wondering where to publish, I cannot say this strongly enough. Do not pay to publish your research. You do not need to pay to publish your research. So find ways to find journals that don't make you pay. For many of our countries, there are fee waivers for open access journals. So if you can get a fee waiver, that's great, but do not pay to do research. They're often trying to take advantage of us. They're called predatory journals. So just stay away from journals that charge. So an open access journal that you do not need to pay for is the East Central African Journal of Surgery that's associated with COSEXA. I would strongly encourage you to publish your research with that journal. As a disclaimer, I'm on the editorial board along with many other COSEXA surgeons. And if you get the opportunity to review for us, understand that it's a free thing and we are really building science from within. So I would encourage you to do that. So in conclusion, research is collaborative. Design a study to answer a question. When you do, this will lead to more questions. And the goal is to advance our knowledge and to advance care. So I really appreciate your time to engage with me in this forum. I recognize that there are really a ton of people, and you are highly encouraged just to learn as you go and make sure that you are learning with others. If you know something, teach others. If you've had an experience, let others know. Because the hope with research is that we build a culture of inquiry where we as surgeons are not afraid to ask questions and to be challenged and to learn. So again, thanks for your time. Looking forward to the next presenter and to all that we are doing and learning. So thank you.
Thank you so much, Bob. Thank you so much for taking us on this session. We do have 7 minutes. If there is anyone having a question, please post on the board, on the chat or in the question and answers. But it is also my honor to invite our next speaker, Professor Koko, who will take us through the first design. I know Dr. Peka has just given the introduction of the overall designs. And remember that we will record all the sessions, and we have your emails and email contact, and we'll share them in due time. So don't worry. I see that there is a lot of questions on this regard. So all the materials will be shared with you. Without taking more time, I see that there are some chats. Yeah, so I think there is no questions. Professor Koko, please welcome and introduce yourself and take us through the cross-sectional design. Thank you.
Yeah, thank you, Sama. Do you hear me?
Yes, we can hear you.
Okay. Yeah, thank you, Parker, for having taken us through such a nice introduction. As you correctly said, we continuously learn. And as surgeons, we only need to understand these concepts, but we'll always find the correct teams to work with. We'll always have different strengths when it comes to research that we can use to complement one another. So I'll be taking you through cross-sectional studies. And normally these are the first studies that are normally done to try to understand some basic epidemiological or disease trends or pattern in daily practice. So as an observational study, the primary purpose is usually to describe and examine the distribution of independent, which is the predictor, and the dependent, which is outcome variables in a population, which is here called the sample. And we try to analyze the association between them. So notably, 3 observational studies are commonly in use, and that is cross-sectional studies, case control studies, and cohort studies, among others. So specifically, cross-sectional study design is a type of observational study or descriptive research that involves analyzing information about a population at a point in time. And I must admit that when you study many of these designs, it comes a point when we confuse, and many of us publish papers that examine patients' outcome, and we try to say it's cross-sectional because we want to think that we collected everything at a specific point in time. So I want us to completely divorce from that thinking, and we will get a fresh understanding on what is actually a cross-sectional study design and what it is not. So in this design, we measure the prevalence of an outcome of interest in a defined population. So generalizability might be difficult if the population changes. And it provides us with a snapshot of the characteristics of the population at single points in time. It can be used to assess prevalence. It can be used to assess the prevalence of outcomes and exposures. And you can also use it to determine the relationships between variables. You can also use it to generate hypotheses about causal connection between factors to be explored in experimental designs. So the design itself is that the investigator measures the outcome and the exposure and the study participants both at the same time. While in case control study, participants are selected based on the outcome status. So you start with a diagnosis, lung cancer, and you look back into the exposure, whether you are interested with cigarette smoking. So you divide them into whether they were smoking cigarette or not. Or in cohort studies where participants' selection is based on their exposure status. So participants in this case will have a shared exposure status. The participants in cross-sectional study are just selected based on the inclusion and exclusion criteria that you set, and it's not based on exposure or outcome status. The investigator follows the study to assess the exposure and the outcome, both at the same time. So normally the purpose of conducting a cross-sectional study is that you want to measure the prevalence of health outcomes and describe the characteristics of the population with that prevalence. So that's why the descriptive nature of the cross-sectional study comes in. So basically you are trying to look at, let's take for instance, you are in a community and you want to know the prevalence of hernia in that community. So you have to define your population which you want to study, and it's a village X. And that village, maybe you are interested with the hernia prevalence among adult males. So you have to define your adult male population and set out to do a survey and look at what's the total number of men in that village and how many of them have a hernia. So, or you examine a group of participants and depict what already exists in the population without manipulating any variables or interfering with the environment. Because if you manipulate or interfere, then it becomes an experimental study. Or you want to describe a variable, you are not measuring it. And this is beneficial for describing a population or taking a snapshot of a group of individuals at a single moment in time. Like you want to look at the prevalence of HIV among patients in your ward on a particular day. or you use it to assess exposure, which is the cause and disease, the effect, and compare the rates of disease and symptoms within the exposed group and the unexposed group. And so in doing this, cross-sectional studies will draw attention for further research through observed relationship. So when a study has qualified the description of being cross-sectional in nature, you cannot use it to change your practice. Like a cross-sectional study is reporting that patients maybe hypertension will be more likely associated with HIV, and you don't know the direction of that association. So we'll never use cross-sectional studies, but they help you to build a hypothesis for better longitudinal studies like cohort or case control study. So in here, we will be seeing three types of cross-sectional studies. The most common and easy one is the prevalence study, which measures the proportion of a population, which we call the sample, with an attribute or condition at a specific time point, regardless of when the attribute or the condition first developed. This is what we call the chicken and egg phenomenon. You don't know whether the chicken came first or the egg came first. You don't care. You want to know how many chickens are there, how many eggs are there. Theological studies are also part of cross-sectional studies where you explore the relationship between risk factors and the disease outcomes, but you'll never make a strong conclusion about any association or relationship that you establish from a cross-sectional study, but you can use it to build an hypothesis for a much stronger level of evidence. Or you do a descriptive study, provide a snapshot of a health status within a population, like we do routinely with our demographic and health surveys for every country. So in descriptive cross-sectional studies, we characterize the prevalence of health outcomes or phenomena under investigation. And under this, we can have three types of measurements of prevalence. You can do a point prevalence, like today in your surgical ward, how many patients are hypertensive? So you call that a point prevalence. Or if you look at that prevalence over a period of time, so maybe you can pick 4 points within a year that you want to measure that prevalence. So you call that a period prevalence. Or you do a serial survey where you do it repeatedly in the same population, the same people you studied, to see how they are changing over time. So the descriptive design starts by identifying the population of interest, and then you collect data from that population, and then you classify the participants as having your exposure of interest or not, or you are having your outcome or phenomena of interest. So participants are recruited based on inclusion and exclusion criteria, and you study the exposure and the outcome both at the same time. So for instance, you cannot say you are doing a cross-sectional study and your question is prevalence of surgical site infection among patients who have undergone an emergency laparotomy, because an emergency laparotomy becomes an exposure, and for surgical site infection to occur, you have to follow up patients. So that cannot be a cross-sectional study. And in many publications, local publications, or in many manuscripts that are submitted to journals, you will find people calling such studies cross-sectional. That cannot be a cross-sectional study. That can be a retrospective or anything like that. So you also want to look at the estimates. What are the estimates that are being used in a cross-sectional study? So you lose things like prevalence of outcome and exposure, or prevalence odds ratio, or specifically odds ratio. I prefer using prevalence odds ratio to differentiate it from odds ratio that we get from a superior longitudinal studies. or the prevalence ratio and risk ratio. Some people confuse this with the relative risk. Relative risk is again for cohort or case control studies. In cross-sectional studies, we call them prevalence ratios. The calculation is almost the same, but the inference you draw from it differ. We'll see a few examples later. But you can also do excess prevalence or a risk difference. You want to see how much prevalence of that disease is attributable to the exposure. And that's what you call excess. That in the absence of that exposure, how much excess risk do we see in that population? So when you use prevalence or odds ratio, we both know, we can recall from our undergraduate statistics that when odds ratio is equal to 1, then it means that exposure did not affect the odds of the outcome. And when odds ratio is more than 1, then exposure is associated with the higher odds of outcome versus compared to the group that is not exposed. And when odds ratio is less than 1, it means the exposure is protective, in that the exposure is associated with lower odds of the outcome when you compare with the exposed group. And when you use risk ratio, again, it's the same, that exposure did not prevent or harm exposed or unexposed group when it is 1. And when it is more than 1, the exposure is harmful. And when it is less than 1, the exposure is protective or less harmful to the group that is exposed. So like when you are using medicine. So if your interest is to establish the prevalence of emergency laparotomy in Moshi Urban. Moshi is a town in northern tourist town in Tanzania, where Mount Kilimanjaro is located. So I'm interested in knowing the prevalence of patients undergoing emergency laparotomy in Moshi Urban. So we designed a population-based survey to assess the prevalence of this population. So you can send out a survey to all households in Moshi, or nowadays many families have a phone that can be reached centrally. So you send out a mobile phone survey that people respond whether they have had an emergency laparotomy or not. So the total population surveyed, for instance, let's say is 5,686, and we find that 98 individuals have had an emergency laparotomy. So the prevalence of emergency laparotomy in this community will be reported as 98 over 5,686, or you bring it per 1,000 population, per 100,000 population, per million population, depending on the prevalence. So in this case, it would be 17.23 per 1,000 population have undergone an emergency laparotomy. So this would be reported as the prevalence of emergency laparotomy in this condition. So can use the same for prevalence of HIV among patients undergoing surgery, the prevalence of anemia, the prevalence of hypertension, the prevalence of diabetes mellitus, the prevalence of CKD, the prevalence of whatever you want to look at, the burden of that disease in a population. So it is very important to establish prevalence of the disease, because it will help you in the planning and knowing how to allocate your resources. If you know the prevalence, if you don't know, you will be chatting you'll be living for a journey without a compass, without a direction. So prevalence studies as inferior as it might be to other studies, but in establishing the burden of a condition, it is very important from a health economics perspective. You will know how many types of sutures you need if you know how many bowel resections you are going to do in a year. So that's the importance of doing prevalence studies. We can also measure prevalence we can also do it as prevalence in some clinical scenarios. Like, what is the prevalence of diabetes or so and so in a population? And we evaluate 300 patients who have undergone an emergency laparotomy. And from them, we want to know how many of them have HIV, diabetes mellitus, hypertension, or CKD, because this might have been existing with these patients or might be the reason why they had a laparotomy. We don't know. So we already know the prevalence of emergency laparotomy, but we want to know how many of these patients actually have any of these conditions. So we evaluate 300 patients who have undergone an emergency laparotomy in the surgical ward at Kilimanjaro Christian Medical Center and Maweni. These are big hospitals in Moshi town again. And we test them for either HIV, diabetes mellitus, hypertension, CKD routinely, and this data is made available. It's normally available in the patient's files. And from this, it turns out that 60 of these individuals have HIV, diabetes, hypertension, or a CKD, whichever one of them. It doesn't have to be all. Thus, we have detected a prevalence of 20% for HIV, diabetes among our emergency laparotomy patients. And the prevalence from this data may have limited generalizability because it is in these hospitals from this population, and we cannot generalize that this is the prevalence of these conditions among laparotomy patients in Tanzania or in Kenya or in Rwanda, because the population studied is very unique to this population only. So another measure of cross-sectional study is prevalence odds ratio. And if your interest is to answer a question like, what is the association between an hypertensive diagnosis and being HIV positive among emergency laparotomy patients? And so these patients are undergoing a laparotomy, and we want to know whether they have got an HIV or not. So trick number one is to be able to know how to create the 2x2 table. And I've always found a lot of problems with the 2x2 tables where the exposure and the outcome are placed. And depending on how you place this, you will have problems with your cross-sectional and all your observational studies. So I will have my outcome in the columns. So I have hypertension and no hypertension, and exposure in the rows as HIV positive and HIV negative. So the odds ratio, just like any other odds ratio calculation, is normally calculated from cell A and cell D. And you divide that with the value in cell B and cell C. So you get the odds of developing of having hypertension when HIV positive of 2.8. So we know that from this, from an odds ratio 2.8 of hypertension when they are admitted for their surgery. But how useful that information is might not be very relevant, that if you have HIV/AIDS patients, they have got that likelihood of having hypertension. So just an hypothetical study, it might not be true. I'm just using hyperboles. So we need to interpret this ratio from cross-sectional study cautiously, because that associated studies as we see this presentation. But to further understand the points of measurements, for it, we need to have confidence interval. So the narrower the strong, the wider the weaker. Used in cross. Okay, thank you. So we can use cross-sectional studies to calculate prevalence odds ratio. And I want you to use prevalence odds ratio and not odds ratio. The formula is the same as that one for odds ratio, but this is for prevalence studies. So it is called prevalence odds ratio. And here we use it to measure association between an hypertension diagnosis and being HIV positive. So as I say, we want to plot properly our 2x2 table because that's where we start. And I want to put my outcome in the columns and my exposure, which is HIV status, in the rows. So we'll have A, B, C, D cells, and we have A over D divided by B over C to get our odds ratio, which is 15 times 215 over 25 times 45, and we get an odds ratio of 2.8. So 2.8 is our prevalence odds ratio. So basically we interpret this, that being HIV positive had a 2.8 odds of developing hypertension among these patients who are undergoing emergency laparotomy. But we need confidence interval to be able to properly understand this relationship between HIV and hypertension. But again, as I said earlier, this only helps us to develop an hypothesis for a better designed cohort or a case control study. We can also use prevalence ratios as measures in cross-sectional studies. And prevalence ratios are often used to compare the prevalence of disease in the exposed group to the prevalence in the unexposed group. So again, using the same cell from our emergency laparotomy, we will be looking at the prevalence of hypertension in the HIV. That would be A over all HIV positive cases, which is A plus B. So that would be 15 over 60. And the prevalence in patients who are HIV negative would be cell C, which is hypertension, which is 25 patients who are HIV negative but having hypertension, divided by the total number of patients who are HIV negative, which is 240, and we express both as percentages. So the prevalence ratio, or the risk ratio here, becomes 2.4. So again, looking back to our previous cell on how to interpret the risk ratios again, just like with odds ratio. So our prevalence ratio is greater than 1. So we are saying that having HIV positive is harmful, as it predisposes to developing hypertension among these patients. So we have seen how to use prevalence odds ratio and the prevalence ratio. And the last measure of effect that we have is what we call the excess prevalence. So excess prevalence is also known as the risk difference. And this provides the difference in prevalence between the groups and indicates how much additional prevalence is due to the exposure of interest. So it means that in the absence of HIV in this case, we would be seeing only this number of hypertensive patients. But because there's HIV, then we are seeing this much number of cases. So like in this case, we go back to the same table. Prevalence of hypertension in HIV individuals was 25%. If you come here, it would be 15/60, and that's 25%. And the prevalence of hypertension in HIV negative would be 25/240. So the difference between that 25 and 10.4% is 14.6%. So 14.6% becomes the excess prevalence of hypertension, which is attributable to being HIV positive in this population. And this is also an important measure to know whether you need to intervene in hypertension or not. So if the excess prevalence is only 1 or 2, then comes the issue of the clinical significance of the finding of the observation that you are making, whether it is worth committing additional resources. So excess prevalence is very important in clinical practice in making some judgments on how you want to allocate your resources, since resources will always be scarce in any community. So we have seen 2 measurements, prevalence odds ratio and prevalence ratio. And so you are wondering whether you require to do all measurements or you do one over the other. And I've always had problems until recently that I realized that you don't need to do both. So prevalence odds ratio is preferred when the study topic is either a chronic condition, it means it will be existing with the population for a longer time, like hypertension, HIV, diabetes. These are chronic conditions. So you want to use prevalence odds ratio as a measure of effect. Or the risk of developing the disease takes several months to develop, like CKD, doesn't occur acutely. You can't use it for ACI, because the moment you study it is resolved, so you will not find it. So you use prevalence odds ratio when the disease takes longer time to develop. But you use prevalence ratio, risk ratio, when you are studying acute conditions, like common colds. If the disease is fatal, like Ebola, you will not use prevalence odds ratio because you will not get survivors. Many people will be dying of the condition. So, but when the prevalence of the disease or your outcome of interest is less than 10% in both the exposed and the unexposed group, so the prevalence odds ratio and the prevalence ratio become equal. So you can use any of them. So what this is exactly telling you is that you can calculate both prevalence odds ratio and prevalence ratio. But then you have to take into consideration what do you want to appear in your paper based on the conditions that I've just summarized above. Since cross-sectional studies are suitable for examining chronic diseases or conditions, then prevalence odds ratio is generally the ideal measure of association to use over the prevalence ratios that we have just learned about. So as a general rule, if you don't remember, just calculate the prevalence odds ratio whenever you are doing a cross-sectional study, and don't forget to do the excess prevalence for your study. But if you can remember, always follow whether the disease is chronic or whether the disease takes several months to develop or whether you are dealing with acute condition. So cross-sectional studies have several advantages, and thanks to Parker, he just highlighted almost all of them, and I'll just be recapping. 1, they are relatively faster, efficient, and cost-effective. Snapshot. You can do it in 1 day, in 1 week. you are done with your study. They are very useful for public health planning, monitoring, and evaluation of effectiveness of programs, like surgical site infection control measures, whether they are working or not working, surgical outcomes monitoring, HIV prevalence in sentinel groups. All this, we can just do cross-sectional studies. They are useful for studying prevalence or burden of disease or condition. As we have said earlier, they are good for generating hypotheses. They are conducted either before planning a cohort study or baseline in a cohort study, and they give information about the prevalence of the outcome or exposure, which are very important when deciding and when you are deciding your sample size for cohort studies. But good things are never without limitations. And cross-sectional studies have many notable limitations, I must say. Remember, it is only a one-time measurement of exposure and outcome. It is difficult to derive causal relationship. Even though we said that we can use it to measure relationship, but chicken and egg, what came first? It's difficult. And for this, it's because there are many biases that are introduced by cross-sectional studies. For example, we wish to study the relationship between diet and exercise and being overweight or obese as measured by BMI. So we conduct a cross-sectional study and we recruit 250 individuals, maybe from MD1 class. We assess their dietary habits, we look at their exercise habits, and we take measurements on their body mass index at one point of time in a cross-sectional survey. However, individuals who are overweight or obese have started to exercise more or altered their feeding habits. So during your 1-point survey, you find, yes, they are obese, they are only eating salad, and they're doing exercise. So your cross-sectional study will conclude that being overweight is associated with taking salad and exercising more. So somebody who doesn't know how to interpret it will say exercise and salad increases weight, predisposes to overweight, which is wrong. So thus we have to be careful about interpreting the associations and the direction of the association from the cross-sectional survey. They cannot be used for rare exposures or rare outcomes because rare exposures will not be there. Rare exposures will not be there when you are studying, and rare outcomes might have resolved by the time you are doing your study. So cross-sectional studies are not very good for that. The prevalence of an outcome depends on the incidence of the disease as well as the length of survival following the outcome. So for instance, even if the incidence of HIV, which is number of new cases, goes down in one particular community, like we know that the global target for HIV is 90% of patients are on ARV, 90% viral suppression, 90% are tested. So we know that people are going to survive. So new cases are not going to be there. Since people are surviving, the prevalence is going up. Prevalence is increasing. So you might think that you are not containing HIV, but yes, the other aspect is that people are surviving. Your medication is working. This may be due to cumulative HIV positive cases over a period. Survival due to intervention, making it insufficient to understand disease trends. And this is what we call survival or selection bias or prevalence incidence bias. So it is very important to understand how to interpret your studies. So you need to be an expert to be able to make this interpretation. They're also susceptible to what we call cross-sectional bias or what we call reverse causation. and the presumed cause is actually the effect, or it might be vice versa. So by carefully considering the potential for reverse causation, researchers can draw more accurate conclusions about the relationship between HIV, for instance, and surgical site infection. So incorrect assumptions: people who exercise regularly are less likely to develop heart disease. This is an incorrect assumption if you do a cross-sectional study, because people who exercise regularly might already be people who are healthy. Because if you already have a heart disease, how can you exercise? So if you do a cross-sectional study, you realize people who have got heart failure are not exercising. And you are concluding that people who exercise more regularly do not have heart disease. So this is a reverse causation, which is difficult. So you need to be very careful in the way you are doing interpretations on cross-sectional studies, or the way you want to use information that you gather from a cross-sectional study. If a phenomenon is transient, like rapidly fatal, or like a short illness, you might miss it. If you want to look for, we said it's a prevalence study, so you want to look at the prevalence of flu in a community. Is it easy? But if you want to only look at the prevalence of flu today, it is possible, because it's only today among school-going children. But if it's fatal, you'll not be able to know whether they had the flu or they died of something else. Limited value to investigate a etiological relationship due to difficulty to establish time sequence of events. You might not know what came first in a cross-sectional study. So it's difficult. You'll be seeing a relationship, but you won't be able to know what came first. Finally, I think one of the biggest problems that even myself have faced severally is to ignore strawberry reporting guidelines for cross-sectional studies. And nowadays, I have strawberry as my important checklist. It's available freely on this website that I've provided in the reference below, equatornetwork.org/reporting guidelines for strawberry. It's a 22-item checklist to ensure transparency in the way you are planning or in the way a cross-sectional study was conducted. And it also allows replicability of the study. If somebody chooses to repeat the same study, and if you followed the strawberry, the strengthening the reporting of observational studies in epidemiology, it will allow your study to be replicable in similar setup. But again, when people are looking for papers to include in systematic reviews, if it was reported according to Strobe, then your study will be used in a systematic review. So it is important to adhere to Strobe guidelines when reporting your systematic review. Here's a list of references that I've used. And once again, presenting as a second presenter, because Parker had assisted me significantly, including the use of elicit, the use of Gen to find a journal to publish in, and the use of other artificial intelligence platforms to help you do your writing. If there is any question, we have a lot of time, and I hope you have lots of questions to ask if you did not ask in the dashboard. Thank you.
Thank you so much, Prof, for sharing that. It was a lot material, so I believe that there are some questions for people continue learning this as we continue this workshop. But I see there is one question on the chat, that is there any guideline for CAP studies for the knowledge, attitude, and practice studies? Is there any guideline that you can recommend, Prof?
Hey, Filippo, I can't hear you.
Can you hear me?
Hello.
I believe we may have lost him.
Yeah, I think we lost Summer.
Can you
Your
hear me?
question, is it? Now I can hear you. I can see
Yeah.
some few questions here. I don't know which one started with you.
Okay. The first one is asking whether there is any guideline for CAP studies, the knowledge, attitude, and practice.
So I can take that one.
Attitude and yeah.
Sure, maybe I can take that one.
Yes, Parker.
So yeah, that's a great question. I think that there are generic checklists for many research designs, and then you can find more specific ones as time goes on. So I just found this one a checklist for reporting and knowledge, attitude, and practice study. I have not read that study, or that checklist, but I think it's helpful to have that. So if you are doing a study, just as Prof mentioned, try to find a checklist that's relevant to you. If there isn't one that's specific to your type of study, you might need to go to the bigger type, like cross-sectional, cohort. But you can find a checklist for many different studies. It's a good question. And I think that's an important point, even in study design. As these checklists are designed for the reporting of studies, but early on, when you're thinking about a study, look at these checklists so you know what you need to know at the end of your project. That's a really good point from Prof.
Yeah, and thank you, Park, for that. I always say that there are many things that you don't know until you check. So always check, always Google and check. There will always be a checklist. If there is no checklist, there will always be an agreed standard of reporting. Look at how others have written their papers, because that's a reporting, and that have been published. So there will always be a checklist. Somebody is asking whether it must always do prevalence odds ratio and prevalence ratio. And I said in one of my second last slides that you don't need to do both. As a rule, prevalence odds ratio is the measure for prevalence studies, because prevalence studies will always be looking at conditions that are chronic or that take longer to develop. Prevalence ratios are ideal for acute conditions, like you walk into a classroom and the children are reporting flu, and you want to know how many children in that classroom today have a flu. So you'll be using the prevalence ratio, because the flus are short, they're acute, and they're short-living. They might not be flu the next day. But when the prevalence of the condition is less than 10, then they are the same. So you can use the prevalence ratio and prevalence odds ratio will be the same. So as my rule, I will always use prevalence odds ratio whenever doing prevalence or cross-sectional studies.
Thank you, Prof. There is another question for both of you. Thank you for your insightful presentation. My question is the last part of the research report, and make it open on the systematic review. Could you please elaborate more on how it works, especially on the ethical background?
I think the question here is, how it's basically on the ethical background. I don't know exactly why ethical background, but if you followed, because when you are finding studies to include in systematic review, one of the checklists is you want to see whether that study design observed the agreed checklist for that design. And that's why you want to use the strawberry checklist for your cross-sectional studies, so that the vigorosity of your cross-sectional studies is not questionable. Then it can be included in a systematic review. But the ethical thing is that all studies involving human subjects must be conducted within the ethical frameworks. So whether you are doing a cross-sectional study, a cohort study, or a case control study, it must be within the ethical framework that's agreed upon internationally. So you have to adhere to ethical framework, and that doesn't have to do with your design.
Okay, thank you.
So there's a question here: if I do research
Sure.
about what causes delayed presentation at a hospital in acute abdomen patients, which subtype of cross-sectional study is it? Can somebody answer? Do we have presenters muted, or they can talk?
Let me unmute.
Can somebody type a response? Maybe somebody can type a response if they have a response. So patients have presented late and they have got acute abdomen. So you want to look at, you must be looking at a factor that led to their late presentation. So you have a factor, maybe by sex, maybe by income class, maybe by village where they are coming from. It's a cross-sectional study. I don't know whether I'm answering you. So you're asking a subtype, like, is it descriptive? Is it analytical? And depending on how much you want to go with it, if you find that factor and you calculate the prevalence odds ratio between factor this and factor this in delay or no delay, then you are using, it will be purely what we consider analytical. If you're only looking at the proportion that is delaying, then it is just a descriptive, which is a point prevalence cross-sectional study. But again, that's not very important in this. Yeah.
Okay, I see other questions about
Meta-analysis versus study trial.
I think we'll have the sessions for this.
I think these ones will be coming, yeah.
Yeah. So someone is asking about membership for
we still have 10 minutes.
Yeah.
This would be a cross-sectional descriptive study. You are looking at various demographic features in glaucoma patients. So it is a descriptive cross-sectional study. Extension prevalence. This is a new term to me. Dr. Abdulkadir Hassan, if you can help explain what this is.
Dr. Kadir, you must be able to unmute yourself if you can explain more on this question. Okay, I think he meant excessive prevalence, but you can unmute and say your question.
Excess prevalence. So if it is excess prevalence, basically you have one group as being exposed, the other group not exposed. So like in my example, the exposure was HIV status. So one group is HIV positive, the other group is HIV negative. And the outcome that we wanted to see was whether HIV exposure was increasing the risk of being diagnosed with hypertension or not. So looking at the prevalence of hypertension among those who are HIV positive as one group, like prevalence 1, and the prevalence of hypertension among those who are HIV negative. Because in our hypothesis, we think HIV is increasing hypertension risk. So we are subtracting the prevalence of hypertension among those who are HIV negative from those who are HIV positive. And whatever we get is the excess prevalence. It means it is prevalence that is existing because of the exposure. So it is the difference of the two prevalence in the two exposure groups. If that's what the question was about.
Yeah, I think that is the question, Prof.
Yeah. So I have provided published papers that had reviewed cross-sectional studies in details, and they are very simple to follow. And I would encourage you to exercise more and try and assist junior colleagues to do cross-sectional studies as you try to develop your gap analysis. I normally like it for gap analysis or trying to show whether a condition is important to study or not.
So Paul is asking whether excess prevalence is the same to attributable risk.
So these terminologies might be confusing, and there are terminologies that will be used in case control and cohort studies that are synonymous to what is being used in cross-sectional. Similar, because you will not use attributable risk in cross-sectional studies, but the same way you calculate the excess risk, excess prevalence in cross-sectional studies might be the same way you'll be calculating the attributable risk for your case control and cohort studies. Just like odds ratio is not similar to prevalence odds ratio. Prevalence odds ratio is for cross-sectional studies, and odds ratio is for the cohort and case control studies. So we have to be careful on what we use where, just like with the relative risk and odds ratio, where do we use them? They almost use the same formula, but different studies.
So there is a question that I've been repeating. Maybe both of you can try and tackle for the time that we have remained. How can we make use of artificial intelligence in helping writing research papers in an ethical way, respecting methodology of the research? Maybe something on artificial intelligence. Prof. or Dr. Pekka, please welcome.
So before Pekka comes in, I think there are papers that have examined the role of artificial intelligence in scientific writing. And artificial intelligence is not entirely unethical, but you have to take responsibility of the content. People had asked whether AI can be a co-author. And I think there is a categorical answer that AI cannot be a co-author. And why people are interested in knowing whether AI can be a co-author? Because co-authors take responsibility of the content. And if you make AI a co-author, then you are telling AI to take responsibility of the content, which AI cannot. So AI cannot be a co-author. So that's very clear. But using AI is not unethical. The problem is if you are not controlling what you are taking from AI. In many instances, you generate an information from AI, and it is not entirely correct. You generate your reference list from AI, and you counter-check, and it is wrong. So you have to take responsibility of whatever you are generating from AI. Like if you are using a licit, Elicit helps you know what reference, what's the abstract, what's the methodology, what did they find, what's their population, and things like that in a tabular manner. And it exactly reminds you how we were taught to do literature review in undergraduate, which we don't do. Many people pick abstracts and write, which is wrong. So Elicit will help you know where to find, which information to find where. So it is up to you now to use your knowledge to now write. So the problem is, somebody asked me to reference him, for instance, write him a reference letter. And I told him, no, since we last interacted, it's 7 years. Tell me about yourself. So he goes to artificial intelligence and generates an information about him, and he sends it. And it was not even talking about him. It was talking like, people called Godfrey Sama are from a village in Moshi. They are hardworking. People called Godfrey Sama are very intelligent people. And I asked him, is this what you want me to write about you? So that was generated from artificial intelligence. That's a bad use of artificial intelligence. So I don't know whether artificial intelligence is unethical. If you say so, then the Google search, the Cochrane, and everything would be unethical too, because they are just improved versions of those. So it is not unethical, but use it responsibly.
Yes, I would also just agree with Prof and what he says, that AI is a tool, and what we're usually talking about when it's involving research publications is generative AI, like ChatGPT or Copilot, and it is a tool, and a tool can be used well or it can be used poorly, and we've seen both, right? So if you use it poorly, it doesn't know that it's doing a bad job. But you can ask it to generate references and it will do it. But it will make references that are complete nonsense. But unless you're very keen, you may not recognize. For example, the ChatGPT, it may just create a resource or a reference that says Profococo, and then next to it, it may say surgical oncology outcomes in Tanzania. And it will look completely legit, right? You would say, well, that makes sense. That's what he does. And this is a good paper to cite, but it might not even be real. It could be hallucinating or making up words. However, so many of us are limited by the way we use the English language. So for some of us, it's our second, third, fourth language. And to try to publish a paper becomes a big challenge. So there are good uses of generative AI. It just has to be really, really well supervised. And whatever you read, you need to take responsibility for. So I'm going to put in the chat, there was a group of journals who came together to kind of give some guidance on when and how to use AI in publishing. So it's not a yes or no answer. There are times where it's good, there are times where it's bad, but as you're learning, you need to be really careful with it because it can ruin your career if you use it poorly.
Thank you so much, Dr. Pekka, and thank you so much, Prof.